All right, so let's talk about, let's start our discussion of cardiac devices. So what is this? We'll see how we're pointing to. This thing over here. What is this thing?
AED pad?
Yeah, so that's an external pacer pad, right? So it's a pacemaker pad, but this is placed externally. So the complication of this requires very high energy, and that can result in skin burst. So that's a transcutaneous temporary pacemaker pad. They come in all shapes and sizes. You might have those that are only anterior. You might have those that are anterior and posterior, right? So can result in cutaneous burn. So very high energy. So this patient is referred for a cardiac MR. A very astute first-year resident, R1 resident, comes to you and says, "Oh, look, there's a wire in here," right? I noticed this on the CT scan. Does this mean that the cardiac MR is contraindicated? Here's the lateral chest radiograph. So what is the wire, and is the MR contraindicated? So what is the wire?
Cardio pacer?
Yeah, so it's a retained pacer wire. The patient's had a sternotomy, right? So the patient's had cardiac surgery before. And so what happens is, after the cardiac surgery, they will place these pacer wires on the heart. These come out through the skin and come out externally. So when the patient is in the ICU, if they need defibrillation, they have direct access to do defibrillation if there's an arrhythmia. When the patient is ready to leave the ICU, they can pull these out, or they will cut the wire. When they cut the wire, then this portion of it remains retained. So it's very common to see these retained pacer wires in patients after they've had cardiac surgery. Now the question, does this mean an MRI is contraindicated? The answer is no. These patients can still have MRI, so it's okay for this patient to go to cardiac MR, okay? So it's an epicardial pacer wire, not a contraindication for cardiac MRI. You might see this kind of strange looking pacemaker. This is called a subxiphoid pacer. So this is used in pediatrics to avoid lead retraction as the patient grows. So this is a way of pacing the heart and to allow the patient to grow while you're pacing the heart. So let's talk about implantable pacemakers, what we need to know about that. So here's a pacemaker. The lead tip is usually placed here within the right ventricle for right ventricular pacing. So we will see it over the apex, on the frontal view, and on the lateral view. So that's a single lead pacemaker. Okay. Here's a patient who has two leads, and then this lead here takes this funny turn. Is that misplaced? Where exactly is it? It's in the right atrium. Is it misplaced, or is that intentional? That's intentional. Why? So where is it exactly? It's in the appendage. It's in the right atrial appendage. So the idea is they'll curl the pacemaker and put it in the appendage, and that tends to keep it fixated so it doesn't move around. Okay, so you will see this curve for the right atrial lead. It's very common. It's nothing to be concerned about if you see that. Okay? So with these are sequential, so it's a right atrium, right ventricle. This helps to improve the cardiac output because by pacing the right atrium in addition to the ventricle, it adds the atrial kick to the cardiac output when you pace both. Okay? This pacemaker was placed on the right side. Why do you suppose usually pacemakers are placed on the left side? You'll notice that most of the pacemakers that you see will be placed on the left side, but this patient has it on the right side. Why is that?
Maybe they're a hemodialysis patient.
So one possibility is the access, right? So is it possible that they can't access the left subclavian vein, right? Mm-hmm. Maybe the patient is on dialysis, maybe the vein is thrombosed or stenosed, and you can't get access through that route, so that's a possibility. But why are most pacemakers placed on the left side?
Most people are righties.
Most people are right-handed, right? And so because of the motion of the right arm, right, that's going to expose the wires to all kinds of shear stress, right? So you'd want to avoid that as much as possible. So that's why most pacemakers are placed on the left side. Most patients are right-handed. But if you have a left-handed patient, you may place the pacemaker on the right side. Okay. Okay. So you can see this patient has two leads. So this lead over here, this guy, where is this guy? That's in the RV. This guy looks kind of funny. It's going way back here, right? So where is that going? That's going in the coronary sinus, right? So when you look on the CT, you can see that that lead is going into the coronary sinus. So is it misplaced? Or is that intentional? Okay. Why? So why would they put a lead like that to go through the coronary sinus? To pace the left ventricle. That's correct. So if you have a patient who has left bundle branch block, when you're pacing the right side, the signal will be delayed to the left ventricle. So then the contraction of the ventricles will not be synchronized. So if you want to synchronize the contractions of the ventricles, you have to have a way of pacing the left ventricle while you're pacing the right ventricle. You can't actually, I mean, you could, but it's not a good idea. You could put a lead in the left ventricle to pace the left ventricle, but why is that not a good idea? What? Well, the first question is how do you get it there? Right? I mean, you could go across the atrial septum and then go down and then put it there, but the more concerning issue is what?
You don't want to form clots.
Yeah, whenever you put a foreign body in the left ventricle, you run a risk of forming clots. If you form clots in the lead in the right ventricle, where are they going to go? They're going to go into the lungs. So what's going to happen? Nothing's going to happen because they're very small. Okay? But on the left side, if you form a clot and it goes out systemically, what happens? You get stroke. Okay? So you don't want foreign bodies in the left ventricle. So to pace the left ventricle, they'll place a lead through the coronary sinus into a coronary vein alongside the left ventricle. And so it's right alongside the left ventricular myocardium. And so that's how the left ventricle is paced. And you can synchronize in the contractions between the left and the right ventricle. Okay. So these are used for synchronizing the contractions, right? Resynchronization therapy. Okay. So we've gone through the venous anatomy, right coronary sinus, anterior interventricular vein, posterior interventricular vein, your coronary veins. So this guy here is the posterior interventricular vein. This guy here is coronary sinus. This guy here is great cardiac vein. Right. And so by going through the coronary sinus, you can get the pacemaker lead into one of these veins alongside the left ventricle, and then that's used to pace the left ventricle after having gone through the coronary sinus. Right. So here's another example. This patient has lead in the right atrium, lead in the right ventricle, and then this one is going through back into a vein for pacing of the left ventricle. Okay. And then you see that's confirmed on the CT. So on CT, you'll actually be able to see the lead going through the coronary sinus. And then this one goes all the way out into the anterior interventricular vein in this patient. Is there a problem here?
Here's pericardial hematoma. So in the context of this lecture, I'm going to assume
Well, how about on the context of the images?
the lead pierced through the myocardium.
Can you see it?
On the top right image, I think the lead is piercing through the right ventricle.
What about the last image?
Last image.
Yeah.
Yeah,
This
it's
guy right there?
outside.
There's the lead tip right there.
Yeah.
Okay. So take home point, whenever you're interpreting a CT, whenever you're looking at a CT scan, in a patient with a pacemaker, if you notice a pericardial effusion, go back and look very carefully at the pacemaker, okay? Because the perforations of the right ventricle can be well tolerated. It's under low pressure. The patient will develop a pericardial effusion, though. So if you notice a pericardial effusion on your CT scan in a patient who has a pacemaker, go back and look very carefully at the lead tip. Where is it? Make sure that, you're not going to miss a case of a perforation. And then here, the lead tip is actually out there inside the pericardium, right? So this lead is perforated the right ventricle. So anytime there's a pericardial effusion, look very carefully. So pacemaker complications, we can have abnormal lead placements, right ventricular perforation. Twiddler syndrome is when patients play around with the pacemaker and actually twist the wires. Lead fractures, most common sites between the first rib and clavicle, in the loop within the subcutaneous tissue near the generator, and at the point of venous entry. Those are the most common sites for lead fractures. So you're familiar with central lines and Swan-Ganz catheters and all of that, and where central lines go. Same principle applies when you're looking at lead placements to determine where the leads are going. After they place a pacemaker, they will get a chest radiograph. They will ask us to interpret the radiograph. So we want to look at the lead placement. We want to make sure it's where we expect it to be. We want to make sure the patient doesn't have a pneumothorax, right? So those are the things that you want to look at when you're looking at these leads. This lead is going back into the coronary sinus, right? So if it's a single lead pacer, it's kind of unusual. So anytime there's a question, call them up and ask them. Look, we noticed the lead's going in the coronary sinus. Is this where you want it? So we've come across cases where that's not where they wanted it. So whenever there's a question about the lead placement, call them up and ask them, is this where you want the lead? Because this is what we see, okay? Here the lead is sitting outside of the cardiac shadow, so clearly this is a perforation, right? So that needs to be reported. And then we've talked about already when you have the lead outside. This is a lot, you'd think this is very easy to do, right? We think the lead's perforated, do a CT, see where the lead tip is. You would think that that's something easy. It's actually harder than it seems because there's so much artifact around this lead tip. There's so much artifact around that. It can be pretty tough to determine where it is. So you really have to sit there, take thin sections, do multiple recons to try to really get an idea of where that lead tip is, before you want to say that it's really perforated the ventricle. But of course, if there's a high attenuation pericardial effusion, you're going to have high suspicion of a lead tip perforation, okay? And then Twiddler syndrome plays around with the pacemaker and you see the leads get all twisted. Whenever you have a chest radiograph on a patient with a pacemaker, you may not get the history, pacemaker malfunction, right? Pacemaker malfunction can be caused by a breakage of a lead. So whenever you have a chest radiograph on a patient with a pacemaker, look very carefully at the leads. Trace the leads out very carefully, right? Look for any breaks in the wires because the first thing they're going to get in a patient with a pacemaker malfunction is a chest radiograph. But you may not have that history, okay? So here there's a break in the casing. So look very carefully, trace out the leads of these pacemakers on every chest radiograph that you review, okay? Okay, so continuing with our discussion of cardiac devices. So what is this thing? What am I showing you here?
AICD.
Yeah, so this is an AICD. So how do we recognize this as something different than a regular pacemaker?
The thickened coils.
It has these thickened coils, right? So anything with these thickened coils, these are going to be the shock coils. So this is an AICD, okay? So it's used for treatment of life-threatening ventricular tachyarrhythmias to prevent sudden death. So there's this pulse generator here, and then, so this tends to be larger, and then you have these shock coils. Sometimes there can be two, sometimes there is only one, but if there's a thickened coil like that, then you can recognize the device as an AICD, as a defibrillator, okay? So you have a lead, usually in the right ventricle for detection of arrhythmia, and then the thickened coil is used as the defibrillation coil. So this thing looks a little bit unusual. So where is this lead?
Is that going up to the aorta?
So how would that get in the aorta?
Maybe through the left ventricle?
So somebody put a hole in the left ventricle and then snuck this lead up into the aorta. First of all, if it's going up into the ascending aorta, what's the course it would take? Would it go up like that? It would go this way,
Yeah.
right? Any other thoughts? First of all, is that a good idea to be sticking holes in the left ventricle and putting?
Probably not.
Yeah, not a good idea. No, not recommended. Any other thoughts as to where this might be?
Could be subcutaneous.
Yeah, so this is a subcutaneous lead, right? So you can see on the lateral view, this is placed subcutaneously, all right? So this device, and we do see these, this is a subcutaneous ICD. So the advantage of this is it's easier to place, especially with patients who have limited venous access. If they have end-stage renal disease, they might have sclerotic veins, so you don't have the access. The disadvantage is that it requires higher shock energy because you're shocking through the chest wall there. There is no pacemaker resynchronization or anti-tachycardia pacing function. It's a defibrillator. And these tend to have a shorter battery life, but you will see these. These are subcutaneous ICDs, so you don't want to get confused when you see a frontal chest radiograph like this about trying to figure out where that lead is going to be. So here's another patient who has an ICD. Is there anything wrong with this?
Looks like the radiation.
Yeah, so this thing, the tip here doesn't look like it's supposed to be as distal as you would want it, and also this shock coil here, which should be in the superior vena cava. So this thing looks like it's backing out, right? And so this is what it's very important to compare with prior studies. This is 11 months prior, so you can see this is what it looked like when it was placed, and then now this thing is kind of coming out. Okay, so you do want to notice those kind of issues with these cardiac devices. So here's a patient who has a pacemaker. Anything wrong with this?
Pacemaker itself, is it?
Nobody's troubled by anything here?
Is the lead too far left? It's way too far to lead.
Well, it's still overlying the cardiac shadow. So, as you follow this, where should this be going? So this should go from here, and it should be going into where? Where should this go? It should go into the subclavian what?
Vein.
Vein? And then where should it go? Here.
Yes.
SVC, and then where should it go? Right atrium, and then where should it go?
Right ventricle.
Right ventricle. Is that what you see, or is there something that's troubling you?
Looks like it's through the, probably the artery into the.
Okay, so the SVC, the superior vena, this patient's not that rotated, but the superior vena cava should be to the right of the trachea, right? And then the lead should come down from there into the right atrium, okay? This thing is displaced too far to the left. It's following the course of what? What did you say, Sawad?
The artery.
Yeah, it's following the course of the artery. And so here we have an echo here, and it's actually coming down the aorta. So this thing was coming down the aorta here, going into the left ventricle. Okay, so instead of getting into the subclavian vein, they got into the subclavian artery. So this thing's going along the subclavian artery, and then from there into the ascending aorta, and then into the left ventricle. Okay. When I first saw this, I thought it was a cigarette lighter. But what is this? Yeah, so this is a loop recorder. So these things are placed in the subcutaneous tissue of the chest wall, right? So these are for detection of intermittent arrhythmias. And so what it does is it will record the heart rhythm for a much longer period of time. They can keep this for up to a year. And the patient can also have a remote control device so that when the patient feels an arrhythmia, they can press it and they can take a more detailed recording. Right? So these are for detection of intermittent arrhythmia, so the patient will carry this around for a long period of time. And then they will get the information off of this to see what kind of arrhythmia the patient had. So that's a loop recorder. That goes in the subcutaneous tissue of the chest wall. Now, this is often mistaken by residents for loop recorders, but you'll notice that this looks a little bit different, right? This looks a lot smaller than a loop recorder. What is this? That's a leadless pacemaker. So that is actually placed inside of the right ventricle. So this is a leadless pacemaker. Okay? So you can see here on the CT, it's actually inside the heart, inside the right ventricle. So that's a leadless pacemaker. Here's a patient who has both, so you can see. It's loop recorder there, leadless pacemaker there. So the leadless pacemaker is a smaller device. It kind of resembles it, but it is a smaller device.
Is that like
How,
the,
how do you distinguish both? The lucency?
It's larger.
Just
See how this one's bigger? See how big this is? So and also the location, right? If it's off of the cardiac shadow, then it's not going to be the pacemaker. But sometimes that can be confusing.
is the leadless pacemaker like new? Or
It's been around for a few years.
Okay.
Yes, so, I mean, I started seeing them a few years ago. Yeah. Okay, anybody know what this is? What? Yeah, so this is a very old type of cardiac valve. It's actually a ball and cage valve, so there's a radiolucent ball in here, right? Now, these haven't been used for years, but we did run across a patient that still had one of these. Right? So that's called a Starr-Edwards valve. It's a ball and cage. There's a radiolucent ball in there, and that's how the valve works. Okay? So these are no longer used. So that's a Starr-Edwards valve. Very unusual to see nowadays. Right? But there are two broad categories of prosthetic cardiac valves. And what are the advantages and disadvantages? So what are the two broad categories? Mechanical and tissue valves, right. So what are the advantages and disadvantages?
Mechanical valves last longer, but you have to hit them.
Yeah, so mechanical valves last longer, but they require anticoagulation. The tissue valves do not require anticoagulation, but they don't tend to last as long as mechanical valves. All right, so that's the basic difference between mechanical valves and tissue valves. So prosthetic valves, as far as mechanical valves, there's the St. Jude bi-leaflet mechanical valve. So that has two leaflets like this, so the leaflets are metallic. And then there's the Carpenter-Edwards porcine tissue valve here. And of course, the struts may be radio-opaque, right? So they might be metal. But the valve itself is not going to be visible, especially on chest radiographs, right? So you're not going to see the valve because that's tissue, the valvular portion of the valve cusps. So the St. Jude mitral valve, if the valves are on FOSS, you might not see them on radiographs, but if they're on edge, like here, then they're pretty easy to see on a chest radiograph. So you can recognize that as a mechanical valve. Here's one in the aortic position. You can see when it's open. Here's when it's closed. So here we're tangential to the valve, so you can see it very well. And then the Carpenter-Edwards valve. So here, as far as on the radiographs, you might just see the metallic struts of the valve. One useful thing is that if you see these struts, if you're trying to figure out what kind of valve it is, the struts point in the direction of the blood flow. Okay, so that can help you differentiate between an aortic and a mitral valve. So another type of tissue valve might be this one, an Hancock porcine valve. So this one has a valve ring. So the ring itself is the radiopaque portion that you're going to see on your chest radiograph or on your imaging studies. Okay? So here's an example here. There's the valve. So for each of these valves, what kind of valve and where is it located? So where is this guy? What position is that? Yeah, it's an aortic valve. Is that mechanical or tissue? Well, if we look really carefully, yeah, we might see the leaflets in there, right? So this one, mitral, mechanical or tissue? Mechanical, right? You can see the metal leaflet. This one, tricuspid, mechanical or tissue? Yeah, this one is tissue. This one you can't see the leaflets at all, right? So these are mechanical. You can faintly see the leaflet there, the metal leaflet for that valve. Okay. This looks a little bit different, right? Any idea what this is? So obviously it's for a valve problem, but is this a complete valve replacement or is this something else? Yeah, so this is an annuloplasty ring, right? So this is used in cases for regurgitation. So in this case for the mitral valve here. So these are used for they can be used for the mitral or tricuspid valve. So these are cases where there's valvular regurgitation because the annulus is too wide, has been dilated. And so the idea here is that you'd want to preserve the native valve as much as you can because that's what's best for the patient. So to preserve that, they can put in this annuloplasty ring, which kind of tightens the valve ring itself to decrease the amount of valvular regurgitation. So this is a mitral valve annuloplasty ring. Okay. Sometimes these are difficult to differentiate from actual complete valve replacement. So you can see they can have various configurations. They can be round, they can be D-shaped like that one. They might have a break in it like this one. Here's also another funny looking type of annuloplasty ring. So sometimes you're not dealing with a complete valve replacement in the mitral position. Also in tricuspid, sometimes you're dealing with an annuloplasty ring. Okay? Now, you would think that if you had to evaluate these valves, of course, the preferred method for evaluating any valve is echocardiography, but you would think that if we had to evaluate these valves with imaging, that you probably wouldn't pick CT, right? Because, what? Metal artifact. Turns out CT's great for evaluating cardiac valves. If for some reason they're not able to get the answer with echocardiography, CT is very good. Of course, you'd have to use retrospective gating, but you can see the valve leaflets very nicely. And with retrospective gating, you can actually look at the valve leaflet function. So CT is pretty good for evaluating these mechanical valves, okay? So there's another one here. This one's in the aortic position, right? So what do you think this patient's problem is? No. What would you say?
Marvin's.
Why? Why did you say
The
Marvin's?
aortic morphology is like
Yeah, what do you call this?
a
Tulip bulb, right? It's a tulip bulb sign, right? So this patient has Marfan's. And what's the problem they get into with the aortic valve with Marfan's? Aortic regurgitation, right? So that's associated with Marfan's. Okay. Here's a St. Jude mitral valve. You can see there, cardiac CT, and then you cut out everything else and just look at the valve itself. Okay? So cardiac CT is a nice way for looking at these valves if you have to do it. All right, so here's an aortic valve, right? Mechanical aortic valve, bileaflet. Anything wrong?
One of the leaflets isn't moving.
Yeah, you see that this leaflet is not moving. What do we call that? It's called a stuck leaflet. I know, that was your next guess. All right, so that is a stuck leaflet. So the leaflet is not moving. Of course, what problem is that gonna cause? That's gonna cause
Regurgitation.
not regurg, but stenosis. Stenosis. That's a stuck leaflet. Okay. Now you can measure the opening angle of these. So what's the opening angle? It's the angle that the leaflet makes here in the completely open position with the plane of the valve, right? And ideally, it should be close to 90 degrees, right? If you think of that, when that's open all the way, it should be 90 degrees. It allows completely unimpeded blood flow. So the normal opening angles are between 73 and 90 degrees for a bileaflet valve. So this also you can evaluate very nicely with CT. Anything wrong with this aortic valve?
Is there a thrombus on it?
Yeah, there's a filling defect here, sitting here along the aortic valve. That's a thrombus. What's it doing? It's preventing the leaflet from opening, right? It's impeding the opening of this valve. So what problem would this person have? Stenosis, right? This person would have stenosis. Okay. So this person has restricted valve motion because of the thrombus there in the valve. One of these is thrombus, one of these is pannus. How can we differentiate between thrombus and pannus?
Which side?
So how does that help?
The thrombus be more on the post leaflet side, and the pans would be on the before the opposite leaflet.
Yeah, so the pannus tends to occur on the ventricular side. So what pannus is it's an ingrowth of fibrous tissue from the endothelium of the heart. Right, so that tends to occur on the ventricular side. Thrombus tends to occur on the aortic side of the valve. Okay. There's another way that might also help if you do a CT with IV contrast. Which of these would enhance more? Which of these would enhance thrombus or pannus? I mean, that's not
The pannus.
the pannus, right? You wouldn't expect thrombus to enhance at all, right? So that's another way that might help. Question?
Is there a reason why the thrombus forms on the outside? The other side of the valve?
No, I don't know. I'm sure there's an explanation, but I don't know what it is. So pannus tends to occur along the ventricular side of the valve. That's an ingrowth of fibrous tissue from the myocardium, the myocardial surface. Tends to have higher attenuation, especially with contrast. It tends to enhance. Okay. Thrombus occurs on the opposite side of the valve. Of course, it tends to have lower attenuation when you're looking at it with CT. So this person has what kind of valve in what position? Is that mechanical or? Yeah, so it's a mechanical mitral valve. Is there a problem?
Is this stuck open?
What?
It's stuck open.
Well, we're just looking at, I'm telling you, we're looking at it in diastole, right? What position would you expect it to be in diastole? Open, right? Any problem though that you see here? There's what? The only communication between the left atrium and the left ventricle should be through the valve, right? What's happening here? There's a leak. This is called a paravalvular leak, okay? And how would this manifest? This was manifest as what? Regurgitation, right, valvular regurgitation. So that's a paravalvular leak, okay? So if there's communication that is outside the valve, here's another example, okay? That's a paravalvular leak. Again, these are things that usually are demonstrated with echo, but we can look for these with CT if we need to, right? Whoops, here's a large dehiscence. This valve actually came apart here. And you can see the large leak here. So this would cause severe aortic regurgitation. Okay. Now, you can also have as complications abscess formation. And the abscess tends to occur in this region, and then that's along the fibrous region of the valve, of the valve insertion. okay, between the aortic and the mitral valves. So abscesses can form here. So if we have low attenuation regions like this in a patient who's had cardiac surgery around the valve, right, that could be an abscess. It's a complication of endocarditis. Okay. What's wrong here?
Aneurysm?
Yeah, so this is actually a pseudoaneurysm, right? So how do these occur? It tends to be in the same location where the patients develop abscesses, right? So how do these occur?
Is it like something with the valve compromising the integrity of the tissues, adjacent tissues?
No, but it's related to an abscess.
Oh.
So what happens? When the abscess communicates with the blood pool, right? If the abscess communicates with the ventricle, now you have a pseudoaneurysm. So you have an abscess collection from endocarditis that can occur along the fibrous portions of the insertion of the valve, and then if that breaks through the wall and communicates with the blood pool, now you get contrast in there, now you have a pseudoaneurysm, okay? So that's usually the mechanism of formation of these pseudoaneurysms that can occur around these valve replacements as a complication of abscess. Right? So it's a pseudoaneurysm, usually secondary to endocarditis after rupture of an abscess. Right? Okay. 1 week after coronary artery bypass graft. Any problem?
That inferior sternotomy wire looks out of place.
Yes, that inferior sternotomy wire is not where you would expect it to be. Now, when you're reading chest radiographs, a lot of you will say sternotomy wires. Say something about the wires. Don't just say, say sternotomy wire is intact. The way you dictate affects the way you think, right? So if you just say, say sternotomy wires and then something about them. Are they intact? Look at them. Are they where you expect them to be? So what complication has this patient had then? Dehiscence, right. So if sternotomy wires are broken and moved, right, especially if they're moved, then you worry about dehiscence, especially in the fresh post-op period like that, right? So this patient has had a dehiscence here. And you can see as we follow the sternotomy down, so those wires are okay there, and then we come down here, and then the bone just splits apart down there, okay? So if sternotomy wires are twisted or moved, you worry about dehiscence. The most common cause of dehiscence is what? Infection, right? And so what happens is because of the infection, the bone and the tissues weaken and the wires tear right through, okay? And then the wires will be moved, displaced. When you compare one x-ray with a follow-up x-ray, you'll see that the wires are moved, but especially if the wires are twisted, right? Worry about dehiscence. So here's another more obvious example, right? You see how these wires are all moved around, these are twisted, right? Big dehiscence, sternal dehiscence in this case. So you do want to notice that. So when you look at you notice sternotomy wires, say something about them, okay? Especially if it's a fresh post-op. So here's a person who has an aortic valve. What's different about this as opposed to the other valves that we've looked at?
On metal leaflets?
Well, that's true. The leaflets are not metallic. That is true. Anything else? There's no sternotomy, right? So what are you looking at? This is a TAVR. So TAVRs look more like cages, right? So these are cages. These will expand and replace the native valve, but it looks a little bit like a cage. So that's a TAVR. Okay. Sometimes, I've seen you guys call these stents. Don't call them stents. Call them valve replacements. So there are two different types that are in wide use now. There's this longer one, which is the core valve, which is this one here, okay? And then there's the shorter one, which is the sapien, which is this one here. So this one, they both kind of look like cages, right? This one is shorter, this one is longer. So these are used in high-risk patients with severe aortic stenosis, although now the indications are rapidly expanding for putting in these TAVR valves. Before a patient has the valve placed, they have a pre-procedural CT scan where measurements are taken because it has to be sized precisely to the valve and where it's going, in the AS and the aorta. So the important measurements that are taken here, the aortic annulus, this area here, the sinus of Valsalva, this area here, sinotubular junction, ascending aorta, the distance from the annulus to the left main coronary artery. That's very important because if this is too low, right, then you can wind up obstructing it with the TAVR. So you have to make sure that there's enough distance between the origin of the left main and where the valve is going to be placed. So these are all important measurements that are taken preoperatively with CT. So that's why these cardiac CTs are done for these patients preoperatively for all these measurements. Now, for measuring the annulus itself, or the so the aortic annulus itself, for measuring this, it's not perfectly round. It's somewhat ovoid, right? So you have to make sure that your measurements are taken perfectly perpendicular to, in multiple planes, in two planes, to the course of this, so that you get a nice, this ovoid structure. Here's your sinuses of Valsalva here, and then here's the annulus right below that, all right? So diameters of this, the circumference of this, these are all measurements that are taken for sizing the TAVR before it's placed. Also, you need to map out the access route. So if the patient has severe atherosclerotic disease with obstruction anywhere along the course, because this is usually placed through the femoral artery, then that's going to impede the access. So that's information that's necessary to know. So they also need to know if there's a unusual tortuosity of a vessel. So if on a particular side, let's say the left iliac is unusually tortuous, again, that would be very difficult to navigate that as they're trying to do the procedure. So that's why you do this total body roadmap, this CT angio of the chest, abdomen, pelvis, also in these patients preoperatively. And so the important information is, how much atherosclerotic disease is there? Are there any severe stenoses along the course of, along the operative route of how they would place the device? Is there any unusual tortuosity? What are the diameters of the vessels as we're coming down, right? So if a vessel is too narrow, then it might not be approachable from that direction. If a patient has chronic renal disease, right, obviously you have to do a CTA, right? What can you do to reduce the contrast dose? Anything we can do?
Dialysis?
No, you want to avoid dialysis. That's the point. They have chronic disease. They don't have end-stage disease yet. So trying to avoid dialysis. Yeah, but if you're right, if you decrease the dose, the problem is you don't get very good enhancement, right? But what can you do?
Oh, do it.
Exactly, right. So dual energy or spectral CT. So with dual energy or spectral CT, right, we can dial down this virtual KEV. So as long as we've done a dual energy protocol, post-processing, we can really bring out the iodine, even though we're using a lower dose of iodine in these cases. So on your standard CT, the vessel may not look very bright, but on your post-processing, when you bring down that virtual KV, then the iodine looks very bright. So with smaller amounts of contrast. Yeah.
Is the downside here just increased dose,
The increased dose? What do you mean?
or like radiation dose?
No, the downside is usually noise, because these images are much noisier. Okay. What about, see these guys? Have you seen these guys before? What are these guys? This is something also we've started to see in the last few years. Any idea?
These like the mitra clips?
Those are mitra clips. Yeah, right. These are mitra clips. So how do these work? So again, these are for patients who have mitral regurgitation. And what they do is they will clip, you see where the valve meets there? So they will clip it here on the ventricular side to decrease the amount of mitral regurgitation. These are mitra clips. So we can see that also on your chest radiograph. So if you see that now, you'll know what it is. And if you might wind up, you see these on CT also, right? You're doing a CT for PE or something, and then you see these metal things here in the left ventricle related to the mitral valve. So now you know what they are. So mitral clips. Okay. Once there was a resident who came to me very frantically about this aorta. What was the resident concerned about here with the aorta? There's air in the aorta, right? My God, what's happening? That's an right, that's an intra-aortic balloon pump. Yeah. So that air in the aorta, if you follow it down, here's the tip of the balloon pump there, right? So this is an intra-aortic balloon pump. It goes in through the femoral artery. And when it's expanded with CO2, and if you happen to catch it when it's expanded, there's gas in the pump, right? And it looks like air in the aorta. So on chest radiographs, you can also catch them when they're expanded sometimes. So here's the tip, and then here it is. Here's the balloon pump that's full of CO2, so it looks lucid on the chest radiograph, all right? That's an intra-aortic balloon pump. Other devices, of course, this guy we know is
Loop recorder?
loop recorder. Yeah. Okay. So the ideal location of these, so these are placed percutaneously through the femoral artery, used in patients with cardiogenic shock, high-risk cardiac surgery patients. So it should be in the proximal descending thoracic aorta. The tip is radiopaque, so you want that between the aortic arch and the carina, right? So you want to, on your chest radiographs, that's where you want to see the tip. Problem is, if it's too high, then when the balloon expands, it might obstruct the great vessels. If it's too low, when the balloon expands, it might obstruct the renal arteries. Okay? So it's filled with CO2, and it inflates during diastole, and that's supposed to improve coronary perfusion, and it deflates during systole, and that kind of helps to act like a suction to increase peripheral perfusion. So that is the theory behind these intra-aortic balloon pumps. And here's another nice example of a balloon pump. So this
That one
one,
wasn't too low.
what?
Well,
This
I guess
one?
it's-
Yeah.
It is
So
low.
it's a little bit low.
Okay.
You could have a. So this one, you can see it's expanding near the renal arteries. Not a good idea. And then this one is way too high. This one is, what's unusual about this one?
It's not inflated,
It's out of the,
It's not what?
out of the aorta.
This seems to be a little too far lateral relative to the course of the aorta. So what's happened here? It's dissection. So while they were placing the pump, they placed it in a false lumen, and the balloon is now expanding within a false lumen. So it's a dissection. Okay. This guy,
PFO.
yeah.
closure
So
device.
that is an atrial septal occlusion device. Yes. So it's used to close pain foramen ovale or small atrial septal defects. So it's an umbrella-like device that is placed through the defect. It will expand on both sides and it grips onto the septum, and so that closes the septal defect. Right? This thing,
Atrial appendage clip.
yeah, so that's an atrial appendage clip or an AtriClip, right? Now this is placed outside the atrial appendage, so it has to be done while they're doing cardiac surgery. So patient has had a sternotomy, and then you have a patient with atrial fibrillation who could develop clots within the left atrial appendage. So while they're in there, they can put the clip over the mouth of the atrial appendage so that those clots are now excluded from the blood pool, or any clots that, potentially would form in the atrial appendage. That's an atrial clip. Anything wrong with this atrial clip?
It's penetrated the wall.
No, remember, it's outside, right? It goes outside. It's not inside, it's outside.
There's contrast in
There's
the
contrast where?
atrial appendage.
In the atrial appendage, right. There's contrast in the atrial appendage, which kind of defeats the purpose. So that means there's a leakage where this thing should be closing the mouth of the atrial appendage. Right? So that you shouldn't see contrast. The whole point of this was to prevent blood from getting in there and to prevent clots from getting out. So you shouldn't see contrast with the left atrial appendage. Okay? This thing, that is a watchman. So this is placed percutaneously, right? And this is placed on the inside. So they go in through the right atrium, across the atrial septum into the left atrium, and then they will place this, essentially it's a plug. This plug goes into the mouth of the left atrial appendage, and it's the same idea. It's for patients who have atrial fibrillation. So it's to exclude the left atrial appendage from the blood pool so that any clots that can form in there would not get out into the systemic circulation. Okay? So that is a watchman, left atrial appendage closed replace. Anything wrong here? What? There's contrast in the left atrial appendage, right? So that means that there is leakage of contrast around the watchman into the left atrial appendage, right? So do they have to redo the procedure? Is this important? Remember, so these patients, after they have a watchman placed, about a month later or so, they will have a follow-up CT looking to see if the watchman is doing what it's supposed to be doing, right? And if we see this, if we see opacification of the left atrial appendage, what does this mean? Do they have to go back and redo the procedure?
Would it fall off over time?
Hmm?
Would it fall off over time potentially?
Well, there is a criteria that we use. Does anybody know what it is? You find the area of communication, right? If that channel is less than 5 millimeters, then nothing is done. If the channel is greater than 5 millimeters, then something needs to be done. So that is the criteria. So if there is opacification of the left atrial appendage distal to the watchman, we look to see if there's a channel around the watchman that we can identify. And then we look to see what is the measurement of that channel. How big is that channel? All right, 5 millimeters is the cutoff for when they become concerned and something needs to be done. Right? If it's less than 5, it can close off on its own. Okay, so this patient has this device, which is what? Yeah, so this is a Swans. What's unusual about it?
Femoral approach.
Yeah, it's coming up the inferior vena cava, directed towards the right pulmonary artery, right? Now there's a second unusual looking thing here too. What is that? What is this? That's an impala, right? So what does that do?
Helps pump blood from the left ventricle up into the
Yeah, so that's a left ventricular assist device. So the way this works is it sucks the blood out from the left ventricle and deposits it within the ascending aorta distal to the aortic valve, right? So this is a left ventricular assist device. This is called an impala, all right? That's what this is. It has this little funny hook at the end that goes in the left ventricle, and then this part here would go above the aortic valve. That's an impala.
This is replaced like a LVAD. Oh yeah.
Yeah, we're going to talk about LVADs in a second, but these are more temporary. So kind of like intra-aortic balloon pumps, right? These are temporary. So left ventricular assist device, this is an impala. This part goes in the left ventricle, sucks the blood out, deposits it in the ascending aorta above the aortic valve. Okay? This is an LVAD. This is a left ventricular assist device. Okay? We don't see these as often now as we used to see them. Why?
Develops. The other devices.
No, that's not the reason.
No.
These were used for what? Why did patients get these?
Or bridge to transplant.
To bridge the cardiac transplant, right. So the idea is to keep the patient alive with this left ventricular assist device long enough until they would get a cardiac transplant. Now, the reason you don't see these anymore is,
Stats.
no, if a patient has this, they're no longer considered a candidate for cardiac transplant. So it's called destination therapy. Destination is the ECU, eternal care unit. So this is now the latest version of the HeartMate 3. So this goes in the apex of the ventricle. It has a tube from here, which goes up into the aorta. So this is the pump. So it takes the blood from there and it pumps it into the ascending aorta. Okay. And as I've said, patients who get these are no longer considered candidates for cardiac transplant, which is why we don't see these as often anymore, because they want those patients to remain as candidates for cardiac transplant as long as they can. Okay, but occasionally you might still run into one of these. That's what it is. All right. Real weird looking device here. What is going on? What is this density? What is that? Air. What is that? Air. What's going on? So what is this?
It's a transplant. Yeah, it's what Scott said.
Well, what is this? Well, you're kind of beating around the bush. You're not telling me what this is. What device is this? Huh? This is a complete artificial heart. Yeah. So total artificial heart. Okay. So the pumps are driven pneumatically, which is why you see the air, right? So it's to replace both the right ventricle and the left ventricle. Right? Total artificial heart. So they remove the native heart and they use the remaining right atrium and the left atrium to attach the artificial heart to. Right? Point of no return. So, do any of these things work out well if you're at this point? So, patient at risk for imminent death from irreversible biventricular failure is when these are used. Right? And so, because the valves here, of course, are all these artificial heart valves from the artificial heart itself. Okay. So regarding pulmonary vein ablation for atrial fibrillation, so paroxysmal atrial fibrillation usually occurs because there are ectopic beats that originate in the pulmonary veins or near the pulmonary veins in about 90% of cases. In about 50%, the source is the left superior pulmonary vein. And it's because there are myocardial sleeves that can extend from the left atrium into the pulmonary veins. So the treatment of this is to ablate the pathways for the ectopic foci to spread the conduction around the atrium. And so what that involves is, for the cardiologist, goes across the intraatrial septum after getting into the right atrium, into the left atrium, and then now what they do is instead of actually ablating inside the pulmonary vein, they ablate the pathways around the pulmonary veins so that if there are ectopic foci of activity, it doesn't spread to the rest of the left atrium. So they will do ablation around the pulmonary veins. And so that prevents the abnormal conduction of electrical activity resulting in atrial fibrillation. Now, before they do that, it's necessary, or in some cases, for us to to map the pulmonary venous anatomy with CT preoperatively so that they know what to expect when they go and do the procedure. Usually this is done with prospective gating. If the heart rate is regular, prospective gating, remember when we're doing coronary artery imaging, we usually do our prospective gating with the window out here at around 75% of the RR interval. But when we're doing imaging for preoperative planning for these ablation procedures, we set our window at 35% of the RR interval. Why is that?
Minimize motion in the pulmonary.
No.
Maximum atrial filtration.
What's that?
We want the atria to be as dilated as possible.
That's correct, right. So you want the atria to be as large as possible when we're examining it with the CT. And remember that the atria is going to be enlarging during the systolic phase of the cardiac cycle. So out here is when the atria is enlarging, and we want to catch the atrium when it's at its largest point. This is also one of those cardiac imaging studies that you can do without cardiac gating. So if the heart rate is irregular, if the patient is in atrial fibrillation at the time that we have to do this, often we will do this without cardiac gating. So this is one of the few cardiac studies that you really can do without cardiac gating. So what is it that we look at? We'll look at the pulmonary veins, the number, location, angulation, the osteal branches, look for any anomalies of pulmonary venous anatomy. Also, we look at the left atrial volume, and that's why you want to do it earlier in the cardiac phase when the atria is as big as possible. And one of the most important reasons is that we want to make sure that there's no contraindication of doing the procedure, like thrombi within the left atrial appendage. If there's thrombus in the left atrial appendage, that's an absolute contraindication to the procedure. And as I've said, cardiac gating is not essential. So if the patient is in atrial fibrillation, we can do the study without cardiac gating, and it's still good enough to evaluate the pulmonary veins. I mean, if you look at if you look at all the PE studies that we do, they're good enough to look at the pulmonary vein. So normally when we're doing this, what we want to do is look at the pulmonary venous anatomy, and the best way actually to see it three-dimensionally is a reconstruction where we look at the left atrium from the posterior aspect. And so the normal pulmonary venous anatomy is we usually have 4 pulmonary veins. And remember, you're looking from the posterior aspect, so this is the left side of the patient, this is the right side. So you'll have superior and left inferior pulmonary veins and the right superior and right inferior pulmonary vein. And that's the normal pulmonary venous anatomy. Okay? In this particular case, is there anything unusual about the pulmonary venous anatomy here?
One left-sided pulmonary veins, not like a common side.
Yeah, so we call this a common pulmonary vein. So you can see here that the vein from the left upper lobe and the left lower lobe are joining to form a common pulmonary vein before they drain into the left atrium. And that's a very common anomaly, to have a common pulmonary vein, and it's usually on the left side. So the left upper lobe and the left lower lobe pulmonary vein join to form this common pulmonary vein. And again, that's usually on the left side. So that's a common left pulmonary vein. What about this case? Is there anything unusual in the pulmonary venous anatomy here?
Is it a fifth pulmonary vein?
What is that? So what is this vessel here, right? So this vessel here that you're not used to seeing, that's coming down to the top of the left atrium. Do you know what that's called? Anybody know what that's called?
Outbreak.
That's called a top pulmonary vein. Yeah. What does it drain? So that is called a right top pulmonary vein. See it here. as we come down, right? So there will be, so from the right side, there will be this vessel that's going to be coming down to the top of the left atrium. You can see it here. There it is, coming down to the top of the atrium. Right? That usually drains the posterior segment of the right upper lobe and parts of the superior segment of the right lower lobe to the roof of the left atrium. So that's the top part. And so the normal anatomy, usually 4 pulmonary veins. Also a common variant is to have separate drainage from the right middle lobe pulmonary vein. Okay? And then here in this example, we have a common left pulmonary vein and also this extra drainage from the right. So the 2 common variants are to have too many veins on the right. That's easy to remember because you have 3 lobes on the right, where the right middle lobe drains separately to the left atrium. And then the other common variant is to have a common left pulmonary vein where you have a common trunk from the left upper lobe and the left lower lobe draining to the left atrium. And then we can do this anatomic map, which they can superimpose also on an electronic map that they also generate while they're doing the procedure, looking for the ectopic electrical activity. So here we are doing a CT scan before ablation for atrial fibrillation. Is there any abnormality here on this image that we need to mention?
Is that left atrial thrombus?
So here's the left atrial appendage, and we notice that it is not filling completely, right? So there's a filling defect here in the left atrial appendage. Now, if you call this a thrombus, that's a contraindication to the procedure, so the procedure will be canceled. So is this a thrombus or is this something else? Yeah, so this is called pseudothrombus. So what is the clue that it's pseudothrombus and not real thrombus?
Straight line.
The straight line, right, there's a straight level here. So in patients with atrial fibrillation, because the atrium's not moving very well, they can have delayed filling of the left atrial appendage. And the contrast is denser than the blood, so you can have unopacified blood like that layering on top of the contrast. So you want to make sure that this is pseudothrombus and not real thrombus, because it does make a difference in terms of how the patient's going to be managed. So what can you do?
Echo?
What's that?
Echo?
What are you saying?
Delay.
Not echo, no. The echo that what they have to do is a transesophageal echo, which they could do, that's rather invasive, but an easier method is what? Delay, yeah, so we did get a delayed CT scan. Right. So just a minute after you injected the contrast, that then allows enough time for the contrast to mix in, and then the filling defect goes away. So this is part of the protocol. So part of our protocol is to include a delayed set of images for this reason. Another thing you can do, especially if on the delayed set, is you still have trouble filling the areas, you can turn the patient prone. You turn the patient prone, that will allow the contrast to fill the left atrial appendage. But delayed imaging is part of the protocol when we're doing imaging for evaluation of the left atrium. Okay? So here's another illustration of a possible complication. What is this complication? Yeah, there's an arrow pointing to it. So there's stenosis of what vessel?
Superior left pulmonary.
That's not the superior pulmonary vein, that is the inferior pulmonary vein, right? The inferior pulmonary veins come in this way, the superior pulmonary veins come in that way. So that's stenosis of the left inferior pulmonary vein. It's not as common as it used to be because nowadays they don't actually ablate at the ostium, they ablate around the ostium. But theoretically, this is a complication that you can't see, stenosis of the pulmonary vein. Here's another example, here's stenosis of left superior pulmonary vein. Then here's an example pre-procedure. Here's the left superior pulmonary vein, post-procedure. You can see the stenosis there, left superior pulmonary vein. What complication occurred here?
Infarcts.
Infarcts from what?
Venous. Occlusion?
venous occlusion, right. This is thrombosis here of the left superior pulmonary vein, and these are venous infarcts. So when you have acute venous thrombosis, if you have acute thrombosis of pulmonary vein, that can lead to infarcts, and these are infarcts from venous occlusion. Okay? What complication is illustrated here? What? Hematoma, right. Where is this hematoma?
On the posterior left atrium.
It's actually in the wall of the left atrium, so it's an intramural hematoma. Notice you have these obtuse angles, very smooth margins, so it's not in the left atrium, but it's in the wall of the left atrium. So that's hematoma that occurred in the wall of the left atrium. Okay? This is the most dreaded complication that can occur from this procedure. So what's going on here?
Near fistula.
So fistula between what and what?
Fistula and the esophagus.
Yeah, so remember that the esophagus sits right behind the left atrium, and if they burn through the wall and get into the esophagus, it can create a fistula between the esophagus and the atrium, and then you can have air here. You can see that there's air getting into the left ventricle, there's some air here in the left atrial appendage. So this is the most dreaded complication, and this usually results in sepsis, and often this is fatal. So this is an atrioesophageal fistula, okay? And that has a high mortality because of sepsis.